That other questions keep coming, sir. I think we'll go to next talk. Dr. Manoria sir is already there. Lot of interest with the new molecules, bempedoic acid launched by many companies. Lot of attention to non-statin therapies. Let us hear about this non-statin based therapy of lipid lowering from Dr. Manoria. Over to you, Dr. Manoria. We're not able to hear you, sir. Please unmute
Hello.
yourself.
You are able
now we can hear you. Go ahead.
So for the next 15 minutes, I'll be talking on rethinking the paradigms with statin and novel non-statin based therapies. So let's see why we are so much interested in lipid management. The first reason is that cholesterol never sleeps. It works 24/7 and executes its ravages on the cardiovascular system in terms of plaque formation in the arteries. And plaques are the major culprit for cardiovascular disease. They put us at risk of heart attack and stroke, and all of us know heart attack is the #1 cause of death and stroke is the #1 cause of disability. The second more important reason why we are so much concerned about lipid management, particularly in the high-risk ASCVD, is the management has reached great strides. So when we look at the issue, can we stabilize the plaque by lowering LDL? The answer is a big yes, data from several statin trials. When we look at the second issue, can we reduce the plaque buildup, which means can we arrest the progression of atherosclerosis? Again, the answer is yes, data from the reversal trial. And it has been seen that if LDL is lowered below 65, this results in arrest of progression of atherosclerosis. And when we look at the third issue, can we shrink the plaque by lowering LDL? That is regression of atherosclerosis. The answer is again yes. And we have excellent data from the GLOVA statin plus evolocumab. And this occurs when the LDL is slashed down to below 50. And when we finally look, can we make the plaque disappear by lowering LDL? This is basically an unresolved issue at the present state of time. While treating these patients, it's very important to remember that lower is better, earlier and larger reduction is better, and sustained reduction is better, and we are lowering LDL to low levels like 30 or so. It is important to remember that the side effects are not related to lowering of LDL, they are related to the drugs which are used for lowering LDL. And in the current era, when we are trying to treat very high-risk patients, we are running the race virtually to the bottom of LDL. So if we look at the ACC/AHA 2018, the target was less than 70, lie ahead of ESC, slash down the target to 50, ESC 55, 40 for a selected subset of patients who develop an ASCVD events while on maximally tolerated statin, and lie created a new extreme risk group where the target is 30. The beauty of lipid management is, unlike hypertension and diabetes, there is no J-curve, so lowest is best for the very high risk patient and the extreme risk patient. This is the Lipid Association new guidelines, and you can see the extreme risk group. So statin is the foundational therapy, and the king statin cannot be replaced. The mechanism of statins are multifaceted, you can see on the screen. But the problem with statin is that the LDL goals are not achieved in 50% of the patient, as you can see in this dialysis registry or the CAFESAs. And when goals are achieved, it results in reduction of the cardiovascular event. So all of us know when statins fail to achieve LDL goals, we use ezetimibe. And when bempedoic acid was not available, we used to use in the affording patients PCSK9 monoclonal antibodies. But now bempedoic acid is available. Improved our lipid management for ASCVD, and you can see the trial showed a reduction in the non-fatal MI, in the non-fatal stroke, revascularization, while the unstable angina, CV death were not much effective. The benefit are more in polyvascular in the improved trial, more in diabetic patients, you can see. And now we have a new kid on the block, which is bempedoic acid, already approved for HeFH or established ASCVD requiring additional lowering of LDL, And the combination is also available, bempedoic acid and ezetimibe in the Western countries, not yet in India. Bempedoic acid, all of us know, is a product. It is converted into an active drug by ASCVD1, and this enzyme is deficient in the skeletal muscle, so the muscle side effects are lacking with bempedoic acid, unlike the statin. It inhibits the enzyme ACL1 and inhibits synthesis of cholesterol ahead of statin. The major side effects of bempedoic acid is hyperuricemia or gout. Other side effects are very rare. And this is the clear program of the bempedoic acid. We have two trials, clear harmony, clear wisdom in the statin tolerant patients, and clear serenity and clear tranquility in the statin intolerant. And there was sufficient number of diabetics in all these four trials. If you look at the magnitude of LDL reduction, it is roughly 15% plus minus 2 if the patient is on a maximally tolerated statin. Statin intolerant, it is 25 plus minus 2, and bempedoic acid plus ezetimibe, it is 35 plus minus 2. So it's very simple to remember. There is sufficient decrease in the HCRP in all the clear program trials. Statin intolerance, you can reduce LDL by 36%, as you can see in the slide. But if the patient is intolerant to statin, don't forget pitavastatin. The chance that pitavastatin produces statin intolerance is much less. This is a trial of the Australian population. You can see this combo, 20 atorva, 180 bempedoic acid ezetimibe, reduced LDL by 63%, 58% achieved LDL goal less than 55. So it was an unaffording patient. This combo trial of oral drugs quite good. And we are keenly awaiting the result of the clear outcome trial. PCSK9 monoclonal antibodies are magic bullets to lower LDL to very low levels. They reduce LDL by 40 to 60% on top of all lipid lowering therapy. The lowering translates into additional reduction in cardiovascular events. LPA lowered by 25%, favorable change across the lipid profile, good safety even up to 10 as shown by the 4A subgroup analysis, no diabetogenicity, no muscle toxicity, and they stabilize the plaque, as we'll see. This is the trial of PCSK9 is stable patient, the 4-year trial. You can see a 15% reduction in the ischemic endpoint. And this is the shows that if you have a higher risk, as you have some MI less than 2 years, the benefit is more compared to MI more than 2 years. Or if you have greater than 2 MI, the benefit is more compared to 1 prior MI. And this is the ODYSSEY outcome trial, which has shown again a 15% relative risk reduction in the ischemic endpoints. CHD death was not effective, but all-cause mortality was decreased. So let's look at the PCSK9 utility in the high-risk ACS. In ACS, there's transient upregulation of PCSK9 levels following ACS. You can see in this slide, the PCSK9 is getting upregulated, and this upregulation has deleterious effect on lipids and inflammation, and it makes the plaque more vulnerable. And all of us know small LDL, small dense LDL, which are highly atherogenic, they are also increased in ACS, and PCSK9 is powered to decrease these small dense LDL, which are highly atherogenic. So does PCSK9 inhibitors also have the so-called pleiotropic effects? And this is a small study. You can see there's a favorable effect on the different components of the lipid profile and also in the inflammatory markers. And this is the quantitative result. You can see small dense LDL also reduced substantially besides LDL and other parameters, and the inflammatory markers are also slashed down. While treating ACS, all of us know that 1 in 5 patients will have a recurrent CV event during the first year post-MI, and the commonest cause of recurrence in post-MI patient is the LDL target has not been reached. When we look at this Sweetheart registry, the risk for non-culprit-related recurrent MI was twice as that to the culprit-related recurrent MI over a long period of follow-up of 8 years. So the message is, even after a successful PCI, you must continue to maintain the target for a very long time to minimize the recurrences. But still more important is that the ischemic risks are greatest in the very early phase in the first 30 years. And therefore, if you are faced with a very high risk patient or the LDL is very high, say 180 or so, you cannot follow these guidelines which says try statins for 4 weeks, again reassess, then ezetimibe, again reassess after 4 to 6 weeks, and then add a PCSK9. Because we know if you don't use PCSK9, the maximum reduction may be up to 70% or so. So if we are faced with a situation of very high risk patient or the LDL is 160, if we are using a triple oral combo, maximum maybe 70 to 75%, and then from 160 you will not be able to slash down to 55 or so. So PCSK9 will be very useful, and therefore in high risk patients, instead of a sequential LDL lowering, combination therapy with 2 or 3 agents should be utilized. So when we are faced with these high risk patients, as you can see on the screen, polyvascular disease or recurrent MI in past or young diabetic stenting, multiple target organ damage, you have to initiate statins, ezetimibe and PCSK9 maybe on the first day. You cannot wait for 4 to 8 weeks or 8 to 12 weeks because there may be a recurrence. We have a panoply of trials of PCSK9 in the acute coronary syndrome, and it is the AVOPEX and AVEX which kicked off the utility of PCSK9 in ACS, and there is a substantial reduction in the LDL, and this is the TCT 2022 trial. In STEMI patients, you can see there is sufficient reduction in the LDL. There was sham control also, and you can see the LDL has been slashed down from 55 to 28. This is the Hydrogen trial, the OCT-based trial, and you can see the plaque has been stabilized, whether you look at the fibrous cap thickness or the percentage change in the fibrous cap thickness or mean FCT, all have shown a favorable increase. Lipid arc is also reduced, so PCSK9 produced plaque stability. And this is the Pacman trial where imaging was done with IVUS and near-infrared spectroscopy in patients with acute myocardial infarction, and you can see similar results, whether it is percentage atheroma volume or the lipid core, burden index or FCT, there was a significant change, and ischemia-driven revascularization was also decreased. Now we have only small studies which suggest benefits of hard endpoint. There are no large randomized trials as yet. For example, in this small study of acute myocardial infarction, you can see decreased readmission rate was observed with PCSK9. Another small study showed decreased risk of ischemic cardiovascular events. As you can see right on the top, the primary endpoint and the secondary p-values are significant. And this is another study with the evolocumab in the extreme high risk. You can see improved prognosis at 3 months. You can see the MACE is decreased significantly at 3 months. Inclisiran is another agent which inhibits synthesis of LDL inhibits the synthesis of cholesterol by inhibiting the PCSK9. And the beauty of inclisiran is unmatched because adherence is very high, because it provides sustained decrease in LDL by 50%, which remains there for 6 months. So 2 injections per day is the schedule for inclisiran. Then we have the REDUCE-IT trial, which was carried out in patients with established CVD, diabetes, risk factor. TG was elevated, showed a significant reduction in the ischemic endpoints, but the benefit was not related to triglyceride because the benefit was same, 150 or less than 150. And we have PCSK9 vaccine, single vaccine, lowers LDL by 50%, remains there for 1 year. If trials come out to be positive, this would be a new way, a booster dose every year to target atherosclerosis. LP-driven cardiovascular disease, all of us know, is a deadly disease, but now pelacarsen is emerging as a transformational therapy for LPA-driven disease and is likely to become a self-revealed disease, and we are on the verge of a new dawn in LPA therapeutic. This is the ASO anti-sense2 ApoA, inhibits synthesis of LPA. The phase 2 trial was strongly positive. You can see 98% achieved target of less than 50, and we are very hopeful that the pelacarsen is likely to come positive in the horizon study. Evolocumab, which is a monoclonal antibody against the angiopoietin-like protein 3, is a boon to HoFH because its action is independent on the density of the LDL receptor. The statins and PCSK are not able to execute their action because many receptors are non-functioning, and this is the Wallensorson study carried out in hypercholesterolemia, which shows a significant decrease. So when we look at the lipid evolution of lipid guidelines from 1980 to today, what do we find? LDL is the primary target, non-HDL is the secondary target. HDL is a fallen angel. All trials of HDL elevation on top of statin has been flop trials. TG is still in search of a large randomized trial showing benefit on top of statins, but LP evidence-based target at the moment we do not have, but the pelacarsen trial is likely to come out positive. In future we'll be having this. The small interfering RNA is in the late stages of early stage of development. Gene editing is a very big step. The first volunteers have already shown positive result. The hard one trial is ongoing. And gene therapy or gene editing is a big stick, because one and done, you never have to come back. And this shows the evolution of lipid lowering therapies. And so in summary, LDL cholesterol is the primary target, has a causal relationship with ASCVD. Non-HDL is the co-primary target. Lowering HDL to very low levels like 30 with up to 10 is safe and provides incremental benefit without any side effect. If you lower LDL to less than 65, arrest of progression of atherosclerosis. If you lower it to below 50, regression of atherosclerosis. And in the today's scenario, LDL can be cut to any size by a panoply of agents available for lipid lowering. Inclisiran has great adherence, but melts cholesterol at a very big price. And icosapentaenol is available in India, and pelacarsen is likely to emerge as a transformational therapy for LPA. Thank you very much.
Thank you, Dr. Manoria. This was an excellent review of non-statin therapy. Just two quick practical questions. You know, there are so many companies which have come with a combination of high-dose statins, rosuvastatin 40 and bempedoic acid. And in fact, they said the risk factor for tendon rupture is high-dose statins. So what are you recommending today?
If we look at the trials of the CLEAR program, tendon rupture was only seen in statin. Tendon rupture was not seen in statin intolerance, which means that bempedoic acid is not directly related to tendon rupture. We have also case reports of tendon rupture with statins with ezetimibe. So it seems that bempedoic acid is not related. When you use with statin, that may be the culprit. But if you want to avoid, you should stop bempedoic acid or in isolation or combination at the earliest. If there's slight evidence of history or past history of tendon rupture, and this usually occurs in renal failure patients, and there are other risk factors. So faced with such a situation, you should immediately stop. But the incidence is very, very rare.
Sir, I think for sake of time, we'll proceed to the next lecture. Dr. Samudraya